Why am I having trouble playing this video? Oh, let's just give it a shot and see.
Should I get started?
Yeah.
No?
Yeah, good.
Okay. Hello, everybody. My name's Dr. Craig Keller. I'm one of the gastroenterologists in the area, and I'll be talking about inflammatory bowel disease today. This is our first time doing these talks remotely, so we appreciate your patience with us. I made this talk today to be geared towards the general public, not necessarily for the medical community. We will keep questions you can submit questions at any point during the talk, but I will be addressing the questions mainly at the end of the talk, just so that we have time to go through everything. And I'll try to make it as interesting as possible for you. So without further delay, we can get started. So this is a little overview of what I'll be talking about today. The two main types of inflammatory bowel disease, or IBD as it's called, ulcerative colitis and Crohn's disease. And for each of these elements, which I thought were important for the general public to be aware of, is how do these diseases present? How do we in the medical community come up with a diagnosis? What is available in terms of medical management? When is surgery indicated? And then just sort of some things to be aware of for long-term health maintenance or even the prognosis of these diseases. So I'll go through each of these separately. So as I mentioned, inflammatory bowel disease is sort of a broad term, which essentially deals with two main diagnoses. One is ulcerative colitis and the other is Crohn's disease. And there are several differences between them, but we in the GI community think of this as mainly the site of involvement as well as the extent of involvement within the GI tract. So ulcerative colitis, as the name implies, is restricted to the colon and rectum. And you can see here, here's my pointer, this picture here on the right shows a typical diagram of ulcerative colitis. Typically starts in the rectum and can extend a variable length up into the colon, and then to involve in some patients the entire colon. Ulcerative colitis, by definition, involves only the very inside lining of the colon or the mucosal layer. And this picture is very small, so it's hard to see, but just the very inside lining. This is different from Crohn's disease, which can really affect any part of the GI tract. As you'll see, most commonly it affects the small intestine and or the colon, and less commonly it can affect other areas such as the esophagus, the stomach, and then it also frequently affects the very bottom, the perianal region or the anal region. So just a little bit about the epidemiology or sort of the population statistics. For the most part, the incidence of ulcerative colitis and Crohn's disease in North America is about the same for each of these diseases. Interestingly, the incidence rate for inflammatory bowel disease is higher in northern locations compared with the southern locations, and it's thought to be, at least in part, a result of exposure to sunlight. There is a growing recognition of association of IBD with vitamin D, so it is something that we frequently check and replace if it's deficient, and that's why patients who live in higher latitude or higher locations or geographies, you see an increased incidence. Typically, the highest incidence of these diseases is in younger patients, so older teenage years to the 30s. But it really both of these can present in any age. There is frequently a second sort of increased incidence in older populations between 50 and 80 years of age. And then for the most part, females are a little bit more affected with Crohn's disease, and the opposite is true for ulcerative colitis. Now a little bit more about the epidemiology. Typically, these diagnoses are more common in Jewish populations as well as in the Caucasian or white population, and a little bit lower in Black or Hispanic populations. Also, something that is very important to know is that smoking is very important in the disease process of both of these diagnoses. Crohn's disease, smoking is associated with an increased incidence of the disease as well as an increased risk of complication from Crohn's disease. And actually, the opposite is seen in ulcerative colitis, where the disease process may be a little bit more quiescent or well controlled in patients who have nicotine use. And then other medications, things like nonsteroidal anti-inflammatory medicines like ibuprofen or naproxen, as well as oral contraceptives or hormone replacement therapy, can show an increase in the risk of these diseases. Okay, so we'll start with ulcerative colitis. You'll see in the diagram here, the colon and the rectum are highlighted in this diagram. So that is where the disease affects. So when we see patients who come into the office, how does ulcerative colitis typically present? And frequently we see patients who have diarrhea, often bloody stools as well. Sometimes because there's inflammation in the rectum, what you get is something called tenesmus or spasm, irritation of the rectum, and that can give you frequent bowel movements or the sensation like you have to have a bowel movement, but not much is there to move. And if the rectum is primarily the only thing involved, then the stools themselves may appear otherwise normal. Also, patients, as with anybody who has an autoimmune disease in general, you can have these more constitutional or systemic symptoms like fever, fatigue, unintentional weight loss. Patients can present with very mild disease, only a few bowel movements per day, and otherwise they feel fine. They can also have very severe, or what we call fulminant disease, and they can have more than 10, 15, 20 bowel movements in a day with severe bleeding, cramping, fever, very, very sick type of picture. The majority of patients that we see with ulcerative colitis present with a mild presentation, far less present with a severe or fulminant presentation. Some of the feared complications from ulcerative colitis, bleeding is a very common symptom, and sometimes patients can have very severe bleeding. Also, if the inflammation in the colon is very severe, this can lead to what's called fulminant colitis or even toxic megacolon, where patients are very sick, febrile, they have a fever, and it can be a surgical emergency. And then if it progresses severely enough, that can lead to colonic perforation, or actually the inflammation leads to the development of a hole in the lining of the colon, which could also be a surgical emergency. These are fairly uncommon in patients with ulcerative colitis, but they are the feared complications. Again, feel free to post any questions at any point during this talk, and then I'll be able to address those questions for you at the end. All right, so presentation, the main presentation of patients with ulcerative colitis involves the GI symptoms, obviously, but both ulcerative colitis and Crohn's disease can present with what's called extraintestinal manifestations, or symptoms that have nothing to do with the GI tract. So these are present in up to 25% of inflammatory bowel disease patients. Oftentimes, these symptoms may predate the diagnosis of inflammatory bowel disease. Some of the affected areas include the musculoskeletal system, so different types of arthritis, whether it's peripheral arthritis in joints such as the hands, the feet, other extremity joints, something called ankylosing spondylitis, which is a disease of inflammation and fusion of the spine, so you can get very bad arthritis in the spine. The eyes are not uncommonly involved in inflammatory bowel disease. Uveitis, episcleritis, other areas, basically just differentiated by the area of the eye that's involved. There are some skin involvement with conditions called, one known as erythema nodosum and the other one pyoderma gangrenosum, and I'll show some images of that to illustrate that. The liver and the bile ducts can be involved in extraintestinal manifestations, something called primary sclerosing cholangitis or other autoimmune liver diseases. And then, as with most conditions that are characterized by chronic inflammation, blood clots and deep vein thrombosis, pulmonary embolism can be seen in these diseases, especially if the disease itself is poorly controlled. Okay, so here's an image of somebody's legs, their shins, which have erythema nodosum. So this is an autoimmune condition where you have inflammation in the tissue underneath the skin, which leads to these red raised areas, which are very painful. That can be one thing that presents with ulcerative colitis or Crohn's disease. And then this is a fairly mild case of what's called pyoderma gangrenosum, which leads to ulceration in the skin. And that can actually be very severe at times, very significant, and can be associated with inflammatory bowel disease. Okay, so when we in the medical field see patients with these symptoms, how do we come up with a diagnosis of ulcerative colitis? Well, as with most things in medicine and gastroenterology, we take a combination of factors into consideration. We obviously start with a history. We talk to patients, and they often complain of chronic diarrhea, weight loss, bleeding, as I mentioned before. We perform a physical exam. We get some lab work. Lab work can show anemia, which is low red blood cell count. That can be due to low iron levels from chronic bleeding. There's something called anemia of chronic disease, which can also present with anemia. Patients can be losing weight, so their albumin levels are low. Other inflammatory markers are elevated. And then we often check stool studies to make sure that there's no infection causing the symptoms. And by definition, this is a non-infectious source of diarrhea. Okay, so this may be a little hard to see here, but I'll sort of describe it. So after we speak with someone, examine them, and obtain lab work, we may also obtain imaging studies, but colonoscopy really is the diagnostic test of choice. And I'm sure many of you have probably not seen colonoscopies very frequently. So let me just explain that on the top here, if you can see my cursor, this is a normal appearing colon. Everything looks nice and healthy. You see these vascular markings in the lining of the colon, and everything looks nice and uniform. As we increase the severity of the colitis, you'll see that we get what's called friability, loss of vascular markings, so you can't see these organized vessels anymore. Everything kind of gets blurred out. As we become more severe, you get what's called contact bleeding, which, as you go through with the scope, the lining is friable and it oozes. And then, as you become more severe, you get severe ulcerations within the colon, which can frequently look very classic for ulcerative colitis, and helps with the diagnosis. And then we obtain biopsies to confirm. Okay, so once we have a diagnosis of ulcerative colitis, what do we do for management? Well, I will sort of talk about the general concepts of management. New medicines and new guidelines are constantly coming out, and it's important to speak with your healthcare provider about the particular treatment for each disease. But in general, with treatment, ulcerative colitis is generally well controlled with intermittent exacerbations and symptoms, intermittent flares, but a small percentage of patients have very, very refractory disease, which is very difficult to control with medicines. So some of the things that we consider that can predict a more refractory disease course, patients who are younger frequently have more active disease. One thing that's becoming more frequently recommended is once we're treating patients and once you achieve what's called clinical remission or your symptoms are well controlled, we may reevaluate your colon either with a colonoscopy or with other types of laboratory markers to make sure that everything is healed on colonoscopy or on biopsy. If it's difficult to achieve this, what's called mucosal healing, that predicts a more refractory disease course. And then as the extent of the colon involved increases and as the disease becomes more severe, it's understandable that the disease would be more difficult to control. Some of the other complications from ulcerative colitis, as you have chronic inflammation, this can lead to scar tissue, which can lead to stricturing or narrowing of the colon. And as with ulcerative colitis and certain types of Crohn's disease, there's also an increased risk of colon cancer. So that's one of the things that we monitor for, and one of the potential complications of the disease. Okay, so how do we treat somebody in whom we diagnose ulcerative colitis? The most important thing to know, as with many diagnoses in medicine, is that every case is different. No two cases are the same. You have to take many things into account: somebody's medical history, age, their ability to tolerate or afford medication, their different things like that, and their experience with previous medications. We typically approach ulcerative colitis treatment into considering how severe is the disease and how far does it extend up into the colon. So with very mild disease, which only involves the very bottom of the colon or the rectum, typically we have suppositories or enemas that can be used. In patients who have more extensive disease, which involves the entire colon or the majority of the colon, we have types of oral medications called aminosalicylates, which can be used. Mesalamine is a common generic name that's used for this. For patients who have persistent symptoms despite these medications, typically we may treat with a short course of steroids. One of the types of steroids is called budesonide, which can be very effective for getting somebody into remission or for achieving remission. For patients who have moderate or even severe disease, frequently we may start treatment with steroids in order to induce or achieve remission, and then we have to switch over to another medication to maintain remission. And frequently that's done with the biologic agents. There are some long terms down here: adalimumab, infliximab, vedolizumab. These are the generic names for some of the biologic medicines or the injectable medicines, whether they're injected under the skin or they're infused intravenously at an infusion center. So this is how we induce remission. Frequent ways of maintaining remission is the same as inducing remission, except for steroids. Long-term steroid use is generally discouraged in inflammatory bowel disease. There's many side effects, and it's actually not as effective as the other medicines. And the overall goal for patients with ulcerative colitis and treatment is to maintain remission, normal bowel habits, and to achieve mucosal healing through colonoscopy without the use of steroids if possible. So this is how we treat ulcerative colitis. Sometimes patients require surgery, and some of the common indications for surgery include those whose disease just do not respond to steroids. You continue to have urgency, pain, bleeding, diarrhea, weight loss, despite every different trial of medication. Frequently, we see patients on the inpatient side in the hospital who have severe or fulminant colitis who fail medications. That's a frequent indication for surgery. We frequently perform colonoscopies at regular intervals to look for what's called dysplasia. And what that is it's precancerous change in the lining of the colon, which has a higher chance of turning into cancer later on. And if patients develop this dysplasia, frequently surgery is recommended to remove that area and the colon. And then other patients who have developed the toxic megacolon, the perforation, or other feared complications are frequently referred for surgery. Okay, and then this is the final slide for ulcerative colitis. Some things that we keep in mind as we develop a trusting relationship in the office, or you do with your healthcare provider. We monitor lab work on a regular basis to monitor kidney function, monitor your blood cell count to ensure that there's no anemia. If patients have long-term use of steroids, then we may get a bone mineral density scan, also known as a DEXA scan. Regular colonoscopies, as I mentioned, on every, say, 1 to 3 year basis are generally recommended to evaluate for this precancerous change or dysplasia. And then it's important to look at the whole picture and to know that inflammatory bowel disease, being a chronic disease, often plays a large role in affecting somebody's quality of life. So we frequently screen for depression and address that if needed. Okay, so that's my topic of ulcerative colitis. As I mentioned before, I'm happy to take questions. You can submit them at any time. and I will address them at the end of the talk. So next I'll get into Crohn's disease. You may see some of the same topics as ulcerative colitis. So Crohn's disease, as I mentioned at the beginning of the talk, can affect anywhere from essentially what we say from mouth to anus. It can affect anywhere in the GI tract. Most commonly, it affects the small and or large intestine, but not uncommonly, it affects the perianal region or down near the anal region. And then less commonly elsewhere upper in the GI tract, such as the mouth, the esophagus, the stomach, or the beginning of the small intestine. Patients with Crohn's disease typically present primarily with abdominal pain, and the reason for this is, as opposed to ulcerative colitis, which only affects the inside lining of the colon, Crohn's disease affects the entire wall of the intestine or of the affected area. So this leads to much greater tendency to develop scar tissue, strictures or narrowings, which can predispose to bowel obstructions. Patients frequently develop diarrhea, and there's multiple reasons for that, whether it's related to inflammation. Certain areas of the GI tract are inflamed and can't absorb bile salt, and then the bile salts can predispose to diarrhea. Frequently, if you have malabsorption, steatorrhea, that's a medical term for diarrhea caused by fat within the stool, can develop. And then if there's what's called fistulas, or communications between different areas of the GI tract that can bypass the absorptive capacity and lead to diarrhea. And then, as with ulcerative colitis, those systemic symptoms of fever, weight loss, and malnutrition can also present in Crohn's disease. So, as I mentioned, fistulas or fistulae are communications or little tracts between different areas of the GI tract. And just sort of a little medical terminology lesson here. Entero generally refers to small bowel. Colo refers to colonic, and that refers to one area of the fistula. So entero or colovesicular fistulas between the GI tract and the urinary bladder can present with recurrent urinary tract infections or air in the urine, known as pneumaturia. Fistulae that go to the skin can create leakage of stool onto the skin. You can have fistulae between the bowel and other areas of the bowel, or even between the reproductive system and the intestine. This can frequently predispose to abscess formation or little pus pockets within the anal region or within the abdomen, which can be significant. Other extraintestinal manifestations of ulcerative colitis. This is very similar to what I had for Crohn's disease. This is very similar to what I had for ulcerative colitis. You'll see many of the same. Here's a little picture of the bile ducts, and in primary sclerosing cholangitis, you have scarring of that, which can lead to liver disease. Patients typically present with Crohn's disease with abdominal pain, frequently in the right lower side of the abdomen because of the area of involvement. They can develop with diarrhea, but they don't always have to. And then fatigue and weight loss. Patients, as with ulcerative colitis, can present with anemia, vitamin D or vitamin B12 deficiency. And then the way we diagnose is frequently on colonoscopy. And then one thing that's important to know, whereas ulcerative colitis is often classic in the presentation and in the diagnostic findings, Crohn's disease can at times be a little bit more tricky to diagnose because it can look like many other disease processes. So we frequently have to put together many different considerations in order to diagnose somebody. So here, these are pictures of the colon during a colonoscopy in somebody with Crohn's disease. Yeah, we frequently in the GI field refer to this appearance as cobblestone. So here's a typical picture of a cobblestone appearance. And then here on colonoscopy, what's classic is that you have ulceration, and then in the areas around the ulceration, everything looks normal. And then as it becomes more severe, the ulceration becomes more intense, and you have these little cobblestones of normal lining popping up in between the ulcers. Some other things, because Crohn's disease can affect any area of the GI tract, colonoscopy does not always pick up the diagnosis. So if we're suspecting small intestinal involvement, there's something called a capsule endoscopy, which is a small pill which has a video camera within it, and a patient will swallow the video or swallow the capsule, and it'll take a video throughout the GI tract, and we, as the provider, can actually watch that video afterwards and evaluate the small intestine that way. We may do an upper endoscopy if upper GI tract involvement is suspected. And then there are other non-invasive imaging tests, certain types of CAT scans, MRIs, other X-rays, which can evaluate the small intestine for any evidence of Crohn's disease. We typically manage these patients frequently in a similar way as ulcerative colitis. We evaluate the extent and the severity of somebody's disease. For patients with very mild or even moderate disease, we may treat them with certain types of steroids, another, budesonide, as I mentioned before, a medication called sulfasalazine. And then as patients develop more severe disease, we have the biologic agents here, as I mentioned, for ulcerative colitis. We have a class of medicine called the thiopurines, as well as steroids. Patients who have abscesses in the perianal region, frequently we need to treat those with antibiotics or even drainage. And here is a sort of a diagram of the perianal and rectal region, and you can see there are many different areas in this region where you can develop a pus pocket or an abscess that needs drainage. Crohn's disease, frequently more often than ulcerative colitis, may require surgery. It's estimated that 10-year risk of requiring surgery for Crohn's disease is as high as 50%. We typically reserve surgery for patients who develop bowel obstructions, they develop an abscess which cannot be drained or controlled adequately with less invasive means, patients who develop bowel perforations, or even have disease which is refractory or does not respond to aggressive treatment. Crohn's disease typically is characterized by intermittent symptoms on a chronic basis, and then can develop, as I mentioned earlier, into strictures, fistula, or abscesses. Patients who are younger, patients who smoke, or patients who require steroids long-term, or even have development of complications in the perianal region, frequently have more aggressive disease. Okay, so this is my last slide. This is just sort of a summary of everything that I mentioned. Inflammatory bowel disease is a common group of disorders of autoimmune disease. The actual mechanism of disease is not entirely clear, but it's thought that patients have a genetic predisposition to the disease, and there's some sort of trigger that turns on their disease and makes it become active. Symptoms typically vary, and as I mentioned before, no two patients are the same, and we as medical providers need to sort of put together the whole picture to come up with a diagnosis. There are many different treatment options available, and frequently new treatments are becoming available, and we take multiple considerations into account when deciding on a treatment for a particular patient. And despite all available treatments, surgery is sometimes required for inflammatory bowel disease. And post-operative, after surgery, outcomes can be very successful. And what's most important is that patients with inflammatory bowel disease, this is a chronic disease, and it requires a long, trusting relationship between provider and patient, and constant monitoring. And with good medication compliance and with close monitoring, regular colonoscopies to evaluate for dysplasia, this disease can be well controlled and can lead to a trusting relationship between provider and physician and patient. So that's what I have to talk about with inflammatory bowel disease. I will take some of the questions and address them right now for you. So pardon with me while I'm trying to deal with technology here. So the first question is, with COVID happening, is it safe to get a colonoscopy? So this is a very important, it's a good question, and this is a very important topic. Obviously, for the past several months, things have been very different in medicine and in society. And it's a common question that we get: is it safe to go to a surgical center? Is it safe to go to a hospital and have a procedure done? And the short answer to that is yes, it is generally safe. In the immediate area in Western New York, we have policies in place in the hospital and other ambulatory centers where patients are screened for COVID, and we use proper precautions, which are recommended by our GI societies to reduce the risk of transmission of COVID. And what's important to know is that controlling somebody's disease adequately is of the utmost importance. So it is generally considered safe, but this is a discussion that you can have with your gastroenterologist or your provider, and they can give you an individualized answer. Another question, why is it important not to put off getting a colonoscopy? So this is very important. In general, for patients who have well-controlled disease, we do colonoscopies for patients with certain types of ulcerative colitis and certain types of Crohn's disease to evaluate for that dysplasia or that precancerous change. Those precancerous changes and even colon cancer develop much more commonly in the IBD population than they do in the general population. And these can develop fairly rapidly. And in order to reduce the risk of development of advanced colon cancer, we do recommend having colonoscopies on a regular basis because any delays in detection of this dysplasia or cancer can lead to adverse outcomes later on in more advanced cancer. All right, next question. Can people with Crohn's still live a relatively normal life? Because this diagnosis can be discouraging for some. Yes, diagnosis of Crohn's disease and ulcerative colitis can be a very discouraging diagnosis. It's a chronic disease. There's no known cure for this disease, no known medical cure, and it can be very discouraging. Frequently, in the medical practices, patients with inflammatory bowel disease and Crohn's disease in general can lead a relatively normal life. What's important is adequate treatment to control your symptoms, and as long as your disease responds to that treatment, you can live a relatively normal life with very few symptoms. So it is possible, and it's important to develop that trusting relationship with your GI provider. Next question, is there a cure? Unfortunately, there is not currently a cure for inflammatory bowel disease. For patients who have refractory ulcerative colitis because ulcerative colitis affects only the colon and the rectum, they can have surgery to remove that entire area, and that's sort of a different topic. But that can remove all of the area of colon and rectum, which can technically be a cure, but there are other things that can develop as long-term consequences to those surgeries, which need to be dealt on a chronic basis. So there's currently no cure, especially for Crohn's disease, but hopefully there will be one soon. And that's it. I think those are all the questions I have. So thank you so much for attending. Hopefully you found this enjoyable, and take care.